Innovation is a team sport, and we are so happy to be here today with Team Canada, live from the headquarters of Accreditation Canada, Vincent Damaris, a patient partner, myself, Leslie Thompson, and the team of Accreditation Canada and Accreditation Canada International. Greetings and hello! We are so pleased to be part of this movement, this fantastic experiment for moving ahead to bring our future health alive. How are we going to bring it alive? We're going to bring it alive by focusing on what we see as the most important, vital sign for health of individuals, organizations, communities, and each and every one of you. The vital sign for our future health is patients included. And today we're going to share some stories about how we've taken that notion and actually put it into action. And we're going to start with the story of Vincent Damaris.
Thank you, Leslie. Thank you for this great introduction. So my name is Vincent Damaris. Someone called me 2 weeks ago a long-time survivor. I was a little bit surprised about that, but actually I think that's what I am. So I've been hemophiliac for 45 years now. So I'm 45 years, so I was born hemophiliac. I've been also HIV positive for 31 years. And I was, like many of my peers, blood contaminated by AIDS and hepatitis C. In the early, but I'm cured of hepatitis C, so I've been living with that for 30 years, but now it's done. I was also a patient activist, you know, at the end of the 80s, beginning of the 90s, so it was different perspective than today, but it was a great experience, and that's when I learned how much patient experiential-based knowledge was important and an added value for peer-to-peer training, but also for the evolution of the healthcare system. I did a kid for 13 years, actually. I was a founder and associate in a strategic consultant firm in Montreal, successful one. Was been sold, and I quit in 2010, and I was invited by the Dean of the Faculty of Medicine in 2010 to promote the patient perspective inside the Faculty of Medicine.
Now, the faculties of medicine are probably one of the most traditional mindsets, but very important
essential
to developing the future players and the people that are going to shape our healthcare system and to influence that patient experience right away. So you entered probably one of the most challenging environments. What happened?
So I started alone, and I started recruiting patients, and the goal we had at that moment is to help our medical students actually to face the new challenge of a changing patient population, you know, more chronic, more informed, more educated, more willing to share knowledge, and when you share knowledge, you share power. So with many impacts on relationship between doctors and patients. So that's what the first goal we had, and it's still a very important goal we have. So today we have 350 patients as trainers inside the faculty, training MD students, but training also healthcare professional students.
Patients are training doctors?
Yes. And not only by giving testimony, but training as expert of collaboration and communication, because that's what we are. We are experiencing, healthcare system on some of us on a day-to-day basis. So we know what it means to collaborate and to communicate. So we are co-teaching with some experienced clinicians, medical students and health professional students, how to collaborate, how to make sense in the way we are in relation together. And we train more than 3,000 students a year.
3,000 medical students a year.
Yes. So we are training the future. But you know, one of the questions we ask ourselves very early in the process is, okay, we are training the future, but what about now? How are we going to change clinical settings now? And then suddenly many CEOs, new visionary leaders like the Dean, emerge and ask us. So there was this recognition that experiential-based knowledge was an added value for quality improvement. And that's what we did in 25 hospitals in Quebec in the last 5 years. And then, guess what? New leaders, research leaders emerge. So many of our national research leaders came to us and asked us to engage patients in their networks, in the governance of the networks.
Why did they want patients
Because
involved in their research?
Because they want to align population needs to research funding. I mean, there's something very important to do here. I mean, it's unbalanced today, and that's what patients and family members bring to those networks. So arrhythmia, pain, stroke, transplant patients, critical care, in critical care also. So, you know, we demonstrate by all those experiences that it was possible, and that experiential-based knowledge is a huge added value for the evolution of our healthcare systems. But it wasn't, this whole story wouldn't have been possible without leaders. It's a huge cultural change, Leslie, you know that. And we need leaders to drive that.
Around patients included is a whole new practice. And I actually learned a great deal about this in my previous role as teaching hospital, where we decided that having patients included in every decision where there was a material impact on the experience of patients, a patient would be at the table. This was the path of Kingston General Hospital. And what we learned through that was many, many things about how to make it real. There's so many practical steps that can be taken. But from a leadership perspective, we started to experiment around the notion of patient-included, patient-inspired leadership. What do leaders do? And I've had many, many conversations with leaders right across the country who say, I get this patient-included stuff. It's really important. I know that I need to be leading and setting the tone of my organization, but how do I do that? And the more we talk to leaders in hospitals, entrepreneurs working in other areas, educators, I'm convinced that it comes down to 4 simple practices. We'll call this patient-inspired leadership, patients-included leadership. 4 simple things to the path forward and turning the idea into reality. The very first is asking yourself, no matter what role, what work you're doing today, have I included a patient today? Before you set out in doing anything, any innovation, design of any product, before you design a curriculum, before you set out and actually walk down the hall to deliver care with the patient, ask yourself, have I included a patient today? And then, have I included the patient today, the voice? What have I learned? What have I learned from that patient today? Once I have that interaction, how do I learn and grow so that that information, and by including the patient, actually has value? You don't stop and say, I've included a patient, I've ticked that off the list. That's not the essence of patient-included or patient-centered care. It's not ticking the list, it's what have I learned from a patient today.
The recognition of the value, added value of experiential-based knowledge of patient is crucial here.
Absolutely, absolutely. And it changes us as leaders when we actually open ourselves up to thinking about all those expert processes that we've had all the time and actually saying, you know what? I don't know it all. It's actually not about me. It's about creating the conditions under which this learning and this engagement can take place.
And sharing values.
And sharing values. So have I included a patient today? What have I learned from a patient today? And the other piece is peopleizing every chance you can get. What the heck do we mean by peopleizing? Well, at the hospital, what we learned, and many of you may have this experience as well, is you look at so many reports and statistics and you can almost become numb. We think about performance of hospitals, healthcare systems, community agencies, organizations, all around this these numbers of performance. How do we measure the health of an organization, the health of a relationship, the health of a community? It's numbers, numbers, numbers. What if you peopleize the numbers? I'll give you an example of a practice that was spawned by an insight that gained from having a patient included in the infection control committee at Kingston General Hospital. So that individual was listening to all the reports on improving infections by 0.08%, and we're moving in the right direction. And she put up her hand and she said, so how many people came into our hospital last month without an infection and then left with one because we gave it to them?
It's a good question.
That is hospital-acquired infection rates brought to life. So when you actually then, as a leader, say, we're going to focus on understanding what we do, and we're going to put a face, a person, we're going to humanize everything, you ask yourself, can I peopleize this statistic, this process? Peopleize isn't a real word. It's not a Canadian word, but it is a word that really, I think, just simply expresses the idea of put a human face and on this whole thinking about including people and bringing the ideas to life. And the fourth is what we're doing here today. That fourth practice as a leader and an influencer and a change agent is sharing your stories.
Yes.
And sharing stories of what you're learning. And you are doing this on a regular basis, and you're helping other patients tell their stories in the environment, working with providers as well.
Yes, and making this story a real education contents for students and healthcare professionals, and it's working very well. It's very efficient. I mean, we are talking people to people, not professional to patient, but people to people. So I mean, it's making a big difference.
So if we think that the including patients makes a big difference. And in fact, there's evidence that's emerging that applying the practices, the simple practices, or that they sound ever so simple, include a patient, listen and learn, peopleize, and share the story so that that can then become part of our own growth and development. And those are so much sense. Why is it so hard?
We used to work together different. So it's a question of balancing things. I'm not only a patient that receives care. I'm a patient who's taking care of myself also. So I'm an actor of care. So it's a question of balancing things, and if you recognize that I'm an actor of care, you recognize that I have experiential-based knowledge that is very rich for me and for you. And we are talking expert to expert now.
Together we're better.
Together we're much better.
So when we think about some of the core practices that are part of assessing a patient, a person, and a relationship, an organization, a community, then bringing patients included into that, the heart of every one of those assessed vital sign is something that actually could really be a powerful lever for change. And that's one of the reasons why I'm so excited to be here at Accreditation Canada and with Accreditation Canada International, because we're in the business of setting standards and helping to inspire and grow and encourage people to strive for the evidence, experiential best of what makes a difference and adds value to patients. So by setting standards and by improving the way in which we reach those standards through processes like accreditation, which typically have never been thought of as very innovative, but really, if you think about what we can do,
it's amazing.
With taking one thing for our future health.
It would be tremendous.
Why?
Because it will help the healthcare system to breathe a little bit more and maybe a lot more. Vital. It's like breathing new air, and that's what patients gonna bring. When we manage all these experiences, making sure that researchers, clinicians, and patients and family members are are meeting together and working together, you can feel this feeling of, everybody is happy to be here and to work together. And that's what's going to happen. And we're going to find new ways of looking at healthcare, new things we didn't.
And we're going to grow
And
new
we're
leaders and
Mhm.
new ways of
Yes.
working.
Yes.
Let's make patients included the new vital sign for our future health. Thank you very much.
Thank you.